for how long? Watu wakina kwa hiyo room. Na unajua nilikuwa different times. Alikaa wait the whole night.
Good evening, everyone. My name is Dr. Nganga. I would like to take this opportunity to invite you to today's webinar. We'll just take a few minutes, maybe 2-3 minutes, to just allow a few people in the waiting room to get in. Once we have a good number, then we can start. As are good, we are still getting in people from the waiting room. At this juncture, I would like us to start off. Today we are going to learn about the role of anesthesiologist in as far as controlling or helping minimize obstetric morbidity and mortality is concerned. And we're very privileged today to have one of the gurus in the field of obstetric anesthesia taking us through the talk. So I'd also want to invite all of us, both from Kenya and outside Kenya, who are joining us for this webinar, and also our partners, the Ferring Pharmaceuticals. Karibuni wote. For questions and concerns, please put them on the chat, and we'll be able to handle them at the end of the presentation. Karibu sana, Dr. Olang.
Okay, good evening, everybody. I'm happy to be here with you to discuss this very interesting topic. Hello. I hope that we shall have a few members in the audience who will help us with the discussions, especially the obstetricians. I've invited a few to join us so that they make this discussion interesting. So, Joe. So I okay. Yeah, so I need to make a few disclosures here. This webinar has been facilitated by Ferring Pharmaceuticals in collaboration with the Kenya Society of Anesthesiologists. Some of the material for this talk have been provided by Ferring Pharmaceuticals. And lastly, I need to say that I have no conflict of interest to declare. So this is the outline of my talk. I'll begin with an overview, and then I'm going to discuss causes and contributory factors of maternal mortality and morbidity. Then I will deal with specific conditions, namely Pph, hypertensive diseases in pregnancy, and sepsis. And I'll present 1 or 2 slides on COVID-19 in pregnancy. Then after that, we'll just do a summary, and then we shall come to the most important part, which is the discussion. So, maternal mortality in obstetrics means obstetric deaths to women that occur during pregnancy, during childbirth, or within 42 days of delivery or end of a pregnancy. The maternal mortality ratio is the number of maternal deaths per 100,000 live births. The current maternal mortality rate in Kenya, as per the records that we have, is 342 deaths per 100,000 live births. This is an estimate from the 2017 Kenya Demographic Health Surveys, which was published in 2019. So what are the causes and contributory factors of maternal mortality as well as morbidity? Number one in the line is hemorrhage. Number two is preeclampsia or eclampsia. And number three, which is not very important in our setup, but very important in the developed world, is sepsis. Now, what are the contributory factors? The contributory factors include inadequate human resource for health, delay in seeking care, inadequate equipment in the institutions, lack of transportation, namely ambulance, delay in referral services. Many times there's breakdown of the only ambulance, or there is no fuel and that kind of thing. Then we have anesthesia-related mortality. So we are going to talk about a few things that will affect our, that cause the contributory factors. Now, in a paper written in May 2016, it was found that anesthesia related, the paper was discussing, was on the anesthesia related maternal morbidity and mortality in the low income and middle income countries. And this was a meta-analysis. And it says, and I have lighted, anesthesia contributes disproportionately to maternal mortality in low income and middle income countries. About 1 in 7 maternal deaths during or after cesarean section was due to anesthesia, 1 in 7. A very high mortality rate compared to what is found in the developed countries. The other thing that this meta-analysis produced, it was a Lancet paper, was exposure to general anesthesia and administration of anesthesia by non-physicians, especially those with no formal training, were the major risk factors for maternal deaths from anesthesia. And for those who have been keeping in touch with the news, there's a new trend now to even ignore the trained anesthetists and have a 5-day training of nurses and other staff to be able to give anesthesia with ketamine. So there is the 5-day ketamine proposal, which was being pushed by certain prominent physicians in this country. Now, it was also noted that although anesthesia is an exceedingly rare cause of maternal death in high-income countries, specific hazards remain, including airway management, high neuraxial blocks, that's high spinal, total spinal, or unintentional dural puncture. Like when you give an epidural for labor and you don't notice that you have actually punctured the dura, and you give an epidural dose into the intrathecal space, then the patient will get total spinal and is likely to die. Now, there was another study where they did a survey. They wanted to know what is the minimum number of specialist anesthetists needed in low-income and middle-income countries. This was a study which was done by the WHO. For those who know members of the WHO Education Committee, you will remember a man by the name Wayne Morris. He was in this study. And then in this study, they said the estimated minimum modest density of specialist anesthetists to achieve a reasonable standard of healthcare, as indicated by the maternal mortality ratio, is 4 specialist anesthetists per 100,000 population. And they concluded that there is a need to train more doctors in many countries so that they can train more specialist anesthetists. The current metro area population of Nairobi, the population of Nairobi currently in 2020 is 4.7 million. From what I could gather from the website of Kenya Society of Anesthesiologists, a survey done in 2017 showed that Kenya had 160 specialist anesthetists, 160 consultant anesthetists. Currently, I would estimate that there are about 200 with most, or just over 200 with most of them in Nairobi. Now, if Nairobi has 200 specialist anesthetists, for example, then we in Nairobi will meet the bare minimum figure of 4 per 100,000 from the calculations. But what does that mean for the rest of the country? For the rest of the country, it means that there are fewer specialist anesthetists, and then we have a number of non-physician anesthetists, but then, and sadly so, we have untrained anesthesia providers. And probably this is one area where we end up with a lot of anesthetic mortalities. Then there was a research article which then was looking at the incidence and predictors of maternal and perinatal mortality and severe maternal outcomes. This was a study done in Tanzania. The main objective was to identify the magnitude and the predictors of maternal and perinatal mortality among women with severe maternal outcomes, who were admitted to Dodoma Regional Referral Hospital. And they found that severe maternal outcome incidence ratio was 40.23 per 1,000 live births. So that is 4,000 per 100,000 live births. They found also that the institutional maternal mortality rate was 459 per 100,000 live births. And they went ahead and found that perinatal mortality rate was 10.83 per 1,000 births. If you multiply that by 100, you will find that there are 1,000 deaths per 100,000 live births. Most of the maternal morbidity and mortality were due to direct causes, in which postpartum hemorrhage and hypertensive disorders were the leading causes. The existing evidence indicates that the top 3 direct causes of maternal deaths in sub-Saharan Africa are obstetric hemorrhage as number 1, hypertensive disorders as number 2, and sepsis as number 3. So moving forward, we we continue with the causes and contributory factors of maternal morbidity and mortality. So we in Kenya realized that there was free maternal health care policy, which was introduced in the country in 2013. So there is a paper which was trying to look for at the effect of free maternal healthcare policy in terms of utilization of health facility delivery services and maternal and neonatal mortality. In this paper, it was found that there was a statistically significant increase in the number of facility-based deliveries. So this was noted that there was that positive impact in terms of institutional deliveries. But there was no significant change in the ratio of maternal mortality and the rate of neonatal mortality. So these findings suggested, as I said, the findings of this study on the free maternal health care policy discovered that cost prevents prevents women from attending hospitals for delivery. But it does not seem to have affected the maternal mortality rate and the perinatal mortality rate. So there must be other factors that contribute to pregnancy-related and neonatal deaths. So this is where we now want to find out if there are other factors, and there must be other factors. Remember, we have mentioned earlier that lack of qualified staff, properly trained staff, could probably be another factor. You may go to a hospital where there's free care, but the people giving the care might not be adequately trained, or they might be lacking equipment, or there might be delay in accessing care, because at the end of the day, once the care has been accessed, it is recorded as somebody who has delivered in the facility. But how early did they come, and what was the condition by the time they arrived? So then there was the issue of association between the mode of anesthesia and maternal morbidity during admission for scheduled cesarean delivery. There was a nationwide population-based study in Japan. So in Japan, when they did that study, they found that for scheduled cesarean delivery, general anesthesia compared with neuraxial anesthesia is associated with greater odds for severe maternal morbidity. This is something I think we know. However, we should be cautious with the interpretation of these findings because they may be explained by confounding indications. If you give a regional anesthetic rather than a general anesthetic to a patient whose condition probably would not, I hope you are still hearing me. So if you give a regional or a general anesthetic to a patient who probably is not suitable for that type of anesthetic, then you may end up with a patient who is complicating not because of the anesthetic, but it is because of the condition of the patient. So there may be confounders in this, but on the general view, it is clear that regional is safer than general anesthesia in cesarean delivery, particularly scheduled deliveries. Now, solutions to lowering these rates, because when we want to look at the broader context of maternal mortality, we want to think of what are the solutions to lowering these rates in the what they used to call underdeveloped countries. There's a paper in 2006 which said that we may actually find that there is no mystery in this high morbidity and mortality among mothers in developing countries, because there are certain things which are obvious, but we do not even think about them. These include improving access to care, reducing poverty, and improving other socio-demographic factors for these patients. Patients who are starved, patients who are malnourished, patients who are anemic, patients who have other issues which are not taken care of will probably have problems. So, is planned cesarean delivery a safe alternative to, say, waiting for a patient to go into labor, complicate, and then you end up running for an emergency cesarean section? So this again has been looked at. Now, This trend is owing in part to some evidence. There is some evidence that suggests that planned cesarean birth may reduce the risk of maternal pelvic disorders such as urinary and fecal incontinence because of transportation issues. Patients may come late and so on, or pelvic organ prolapse, or may decrease the risk of unexplained stillbirth and neonatal morbidity associated with cord prolapse, chorioamnionitis, fetal heart rate abnormalities, and breech presentation when compared with vaginal delivery. And these days, you get people coming for primary cesarean section. They say they fear they might lose the baby if they wait until their term, or if they wait and then they find themselves too far away from the hospitals. But then, in the planned cesarean group, the overall risk of severe maternal morbidity, was noted to be 3.1 times greater than in the planned vaginal delivery group. So if vaginal delivery is planned properly, it is still safer than a planned cesarean delivery. This includes the increased risk of postpartum cardiac arrest, wound hematoma because of cesarean section, risk of hysterectomy again because of cesarean section, major puerperal infection, depending again on where your facility is. Then we get the risk of anesthetic complications. Then you have venous thromboembolism, which is related to post-op mobilization and so on and so forth. And then the risk of hemorrhage requiring hysterectomy tends to be higher in cesarean delivery than in vaginal delivery. So those are some of the factors that then make it really a difficult decision to say that planned cesarean childbirth is safer than planned vaginal delivery. In fact, planned vaginal delivery appears to be safer, but again, it will depend on the condition of the patient, why they want a planned delivery, and so on and so forth. And that's where the obstetrician comes in, and then they agree on what is the best thing to do. Now, there was an increased rate of postpartum hemorrhage in Australia. So in a study done in 2007, it was noted that increases in postpartum hemorrhage are probably not explained by the changing risk profile of the women. What may have happened in a developed country like Australia, that they were beginning to see more postpartum hemorrhages than before. And then they said maybe it may be due to changes in the management or reporting of the postpartum hemorrhage, which have resulted in higher postpartum hemorrhage rates. Maybe the reporting has increased. Maybe in a country like Kenya, we report them less, so that even the number that we see might actually be an underestimate of the actual figure. And yet, in the developed world, because they now were able to report them better, they found that the numbers were increasing. Now, was it really because of the changes in management of the patients, or was it because of changes in postpartum hemorrhage? So those are some of the factors that one would really like to look at. So we then now go to an issue of, this is some information I got from a paper from the WHO, which now wants to talk about specific problems that are causing maternal morbidity and mortality. And we start with postpartum hemorrhage. And it says that worldwide, about 500,000 women die as a result of complications of pregnancy and childbirth. Majority of these deaths occur within few hours of delivery, and in most cases are due to postpartum hemorrhage. A major cause of maternal morbidity and mortality worldwide is Pph, and Pph is the leading cause of preventable maternal morbidity and mortality. And it has the highest incidence in low and middle resource countries. Kenya is no longer low resource country, it is a middle resource country, it's a middle income country, according to the classification of the World Bank. Now, 60 to 90% of the deaths from PPH are potentially preventable with better medical care. And better medical care includes accessibility, it includes staffing, it includes provision of equipment and medications and all the factors, including blood availability. So there are many factors there that will affect. Now, the World Health Organization also reports that maternal hemorrhage complicates 10.5% of all live births, and it is responsible for up to 30% of all maternal deaths annually. And most of these deaths are in the developing countries. Effective management requires multidisciplinary, structured approach with the recognition that PPH can rapidly become life-threatening. You don't wait for it to happen. You really need to foresee, if possible, that this can happen. And as we go on, we'll let you know what. So PPH could be primary or secondary. So there could be secondary PPH and primary PPH. Primary PPH is the loss of more than 500 mL of blood within the first 24 hours of delivery, or loss of any amount that is enough to cause hemodynamic instability in the mother, or loss of more than 10% of the total blood volume. What I normally do is, if the blood loss I see, because sometimes you don't see how much blood is being lost. Sometimes it is dropping in the drapes, sometimes it is dropping on the floor, and you don't see as an anesthetist. What I usually say is that if you find that you are chasing the blood pressure, you find that the blood pressure drops, you give fluids, then it goes up, and then begins dropping again, then you are already in PPH, and you really need to do something, because that patient will need blood transfusion. Secondary postpartum hemorrhage is bleeding in excess of normal lochia after 24 hours. And up to 6 weeks postpartum, you can still have postpartum hemorrhage. In both cases, the true blood loss is often underestimated. And this is a fact that we must all remember. It is always underestimated. And of course, there are jokes about the estimation of blood loss. Many times you find that the blood loss estimated by the surgeon tends to be lower than the blood loss estimated by the anesthetist, and therefore it always brings that discrepancy in writing notes. So the best thing I do is we agree with the surgeon, the middle ground, and we say, yes, this blood loss is more than 500. This blood loss is actually so much that we need to transfuse the patient immediately. The risk of dying from postpartum hemorrhage depends not only on the amount and rate of blood loss, but also the health status of the woman. And that again is one of the factors that we said might be affecting our patients in the low and middle income countries. Much as they will seek care in the public hospitals where there is no charge, they may themselves be in a poor health status. And that's why we are not seeing a decrease in the maternal mortality, morbidity and mortality, in spite of free maternity services in this country. So what are the things that cause this? How do we classify the causes of PPH? There are basically 4, and they usually, and everybody knows, they are the 4 T's. And this is the tone, uterine atony. This is the inadequate contractile response of the uterus after delivery. And it's also the commonest cause of PPH. So usually this is where you have an issue. And sometimes it is probably because the bladder is distended. And when you catheterize the patient and massage the uterus, you might find that the uterus contracts very well and everything stops there. But it requires that one knows. Then trauma, which includes lacerations, hematoma formation, inversion and rupture of the uterus, also cause severe bleeding, and contractility of the uterus becomes compromised. Then tissues, retained products of conception. Invasive tissues such as the placenta, placenta accreta, placenta increta, placenta pacreta. This can be diagnosed preoperatively. If diagnosed preoperatively, then it is the best way of doing it, because then you plan. You diagnose with an ultrasound. You also diagnose by seeing increased serum HCG, alpha fetoprotein, or you might notice it as Pph after delivery. You have removed the placenta and apparently the placenta is not complete. MRI is useful prenatally as a complementary technique, especially where it is available. If it is not available, then that will probably not help you, because you are likely to meet the placenta accreta or pacreta when the patient is already in Pph. Then, of course, the fourth T is thrombin, which is coagulopathy. The possibility of an inherited bleeding disorder should be considered in situations of unexplained and recurrent hemorrhage. Sometimes you find the patient continues hemorrhaging, and you really need to do a full blood count, see whether it is a platelet issue, see whether they get better history, whether there is a bleeding disorder. And usually it is important to find out, especially patients who are coming for repeat cesarean section, for them to tell you what happened during the previous cesarean section. Many will tell you, when I had the last cesarean section, I bled, they transfused, I was even admitted to ICU. Such are the patients you prepare early to manage better in case they develop that Pph. So you get your blood, group and cross match at least 4 units of blood, talk to the hematologist and say, I have a patient who bled severely the last time, so in case we need help, we shall let you know. Pph can be the first indication of what von Willebrand syndrome or disease, and this has been seen. And von Willebrand factor plays an important role in the hemostasis by facilitating platelet adhesion and acting as a carrier protein for coagulation factor 8. Regional anesthesia is considered safe in patients with third trimester von Willebrand factor levels, which are 50 international units per deciliter or more. So the fact that a patient has von Willebrand's disease does not mean you cannot give them a regional anesthetic for cesarean section. But you need to then, if it is a known case, then you need to check the level of the factors, and that I think can only be done in big centers like Nairobi. Other bleeding disorders include deficiencies of other factors, deficiency in prothrombin, in fibrinogen, and factors 5, 7, 10, and 11. Therapy for patients with the bleeding disorders consists of hemostatic agents such as tranexamic acid and desmopressin. Tranexamic acid should be available anywhere in this country where they do deliveries. Multidisciplinary team is always recommended. Don't begin looking for the surgeon when you knew very well that this patient had abnormal placentation or had a high risk of bleeding. Don't begin looking for blood when you knew very well that this patient had a bad history. So what is the role of the anesthetist? The anesthetist is very important in the multidisciplinary approach. The obstetrician, very important. You have to communicate with the obstetrician. You need a hematologist. You need a pediatrician. You need a surgeon. You need to communicate with the midwives and the operation room staff. So it is a big team that must all work together in unison to be able to save this patient. Of course, in our setup, you might find that there's shortage of staff, which is one of the things that makes life very difficult. So what are the general principles of managing obstetrical hemorrhage? Although specific interventions will be required depending on the underlying cause of hemorrhage, there are several basic steps that are essential in the management of obstetric hemorrhage. Early recognition and multidisciplinary team approach is very important. Restoration of blood volume with fluids, blood, and blood products. You must have good peripheral lines or a central line if the need arises, and you must be able to restore the volume. Don't wait for the patient to go into irreversible shock. Conservative measures such as uterine cavity tamponade and sutures. Then you also know about uterotonics, for example, oxytocin, carbetocin, egometrine, misoprostol, and always communicate with your surgeon and the nurse, the midwife, so that you make sure that you work together in unison. Then you need to correct the coagulopathy that may be there with blood products and coagulation factors. You need to have them and provide them promptly. Again, these are some of the things that are easier said than done, depending on which part of this country you are in. If you are in Nairobi, if you are probably in Mombasa, the big cities, it's probably very easy. So it is ideal that very sick patients, the high risk patients, should be referred to the tertiary institutions. I remember when we were students, KNH would never do ordinary normal cesarean sections. They were doing deliveries for high risk pregnancies, and there was a high risk pregnancy clinic, antenatal clinic, which I think is still there. But these days we admit anybody, so it makes life very difficult, because then we end up chasing the numbers so that we clear the list. Now, interventional radiological procedures, we have them. They are available, but only in the big hospitals where they can do internal iliac artery balloon placement and things like that. But again, these are things that you have to plan in advance so that you don't begin looking for the interventional radiologist in the middle of a procedure with a patient who is bleeding and unstable. Then it becomes difficult. Again, it might be difficult to move a patient from the theater to the radiology department. So those are things which are probably easier said than done. So we have to consider all these as factors that can make the management of obstetrical hemorrhage very difficult. Remember, infusion of large volumes of cold crystalloids and colloids in a patient with PPH can end up causing hypothermia. It also causes dilutional coagulopathy. It can cause metabolic acidosis, especially if your pressures have been low for too long. It causes tissue edema and tissue hypoxia. Therefore, you must limit all these, but at the same time, again, you deal with your surgeon, you agree with your surgeon. One of the things is that there are specific procedures like getting the arteries so that there is less bleeding. And sometimes you just have to block everything and think about what next as you even wait for help. And if the decision has to be made about doing a hysterectomy, it is a decision that does not wait. The surgeon must make that decision, and you must go along with that decision and save the situation. You can always explain the rest later. Because even if this is a patient who is having a first baby, and maybe even the baby you are delivering has died, if it means removing that uterus to save the mother, then you have no choice. You have to remove the uterus and save the mother. So those are things that must be considered. And that's why I've said this is multidisciplinary, it is teamwork, it is something that you don't want it to go out of hand. You have to be in charge, you have to be in control. Now, an initial massive transfusion protocol with 1:1:1 fixed ratio of RBCs, fresh frozen plasma, and platelets generally satisfactorily maintains microcirculatory perfusion of the brain, the heart, the lungs, kidneys, and other vital centers. So you must be clear in your mind that these are things that you can do. So for cesarean sections that have a high risk of hemorrhage, you must plan ahead. I see times when a patient is known in the clinic to have placenta previa, known in the clinic to have placenta accreta, and then people do nothing until the time when now the patient is in theater and is already bleeding. That's when people are running helter-skelter, trying to look for help from everywhere. So early multidisciplinary team planning is important. Availability of obstetric, radiologic, surgical, and anesthesia personnel with the aim to reduce blood loss and morbidity is very important, as well as to possibly preserve the uterus, because you want to preserve that uterus. But the point on this slide is you must plan ahead. So you need to consider prophylactic internal iliac artery balloon for occlusion and embolization by interventional radiologist where that is applicable. Where it is not applicable, you still need to do something that is going to save the patient. Availability of blood and blood products from the blood bank. This is a tough situation. If you anticipate PPH, group and cross-match, 2 to 4 units in readiness. Have at least 2 units of packed red blood cells in the operating room prior to the start of the surgery. Because there are times when the lab tells you they have the blood, but the moment you need that blood, you are told to give them another 30 minutes or 1 hour. That will not help you. So potential massive transfusion protocol must be planned ahead. So that's part of the planning. Then you must have equipment available for rapid fluid infusion, warming devices. Make sure patient has 2 large IV, 2 large bore IV lines, gauge 14 or gauge 16. And when it is necessary, have an arterial line or a CVP line placed before surgery if you think that you will need it. If I have a patient whom I expect, like a patient with invasive placenta, I would probably want to be very ready right from the beginning. So how do you manage anesthesia as part of the prevention of maternal morbidity and mortality? Regional anesthesia is preferred, but in some parturients, it may be contraindicated. So you need to consider if there's a need for emergency delivery where you people are running. There's no time for positioning the baby, the mother, and doing a lumbar puncture and giving the medication. That's a waste of time. If your patient has significant hypovolemia, there's no room for regional anesthesia. If your patient has coagulopathy, again, there's no room for regional anesthesia. So much as I've said that it's safer to give a regional anesthetic for obstetric cases, there are exceptions, and these exceptions must always be considered when talking about regional anesthesia. So even as we continue managing postpartum hemorrhage, it is imperative to monitor such patients after surgery in the ICU or the HDU, or better still, in some smaller hospitals, the post-anesthesia care unit will be useful to monitor the patient until the patient is stable hemodynamically. And I tell my anesthesia colleagues that when your patient needs blood, it is your responsibility to transfuse that blood. Don't say in the treatment sheet, transfuse 2 units of blood. No, transfuse that blood, hemodynamically stabilize your patient before you go away, because asking somebody else to do it for you might end up in disaster, because that person might not even see the urgency of transfusion. And then there are some people, particularly our nursing colleagues, who have such specific procedures to follow that if they have not written the chart, they still don't have the time to monitor the transfusion. They have not finished with another patient so that they can come and stabilize your patient. They will take time before starting the transfusion. So do not send a patient to the ward, an unstable patient to the ward for transfusion. Tranexamic acid, I'm repeating it, is an antifibrinolytic drug, and the WHO recommends it in PPH regardless of the cause of that PPH. Tranexamic acid should be administered within 3 hours following by the vaginal birth or cesarean delivery. Delayed use of tranexamic acid reduces the benefit with no effect seen after 3 hours. So don't delay in giving your tranexamic acid. So what are the surgical interventions? Surgical interventions are often required to treat patients with PPH, depending on the cause of bleeding and the expertise of the team. The team will only do what they are trained to do. So the commonly performed interventions are manual removal of the placenta, repair of lacerations, intrauterine balloon tamponade, uterine compression sutures, the B-linge, pelvic vessel ligations, internal iliac, uterine, hypogastric, or ovarian arteries, interventional radiological approach, which we have mentioned, which are intra-arterial occlusion and arterial embolization. And finally, there is the good old hysterectomy. If you must save the life of that mother through hysterectomy, go ahead. But it is a decision that you must make as a team. What is the role of the anesthesiologist in the management of preeclampsia and eclampsia? That's the second major cause of morbidity and mortality. Control. The anesthesiologist's role is to assist the obstetrician in the control and prevention of further convulsions. You need to control the blood pressure. You need to establish a clear airway. Make sure your patient is breathing well. If your patient has convulsed and is unconscious, then you must make sure the patient is stabilized and is breathing before you even rush for cesarean section or any other mode of delivery. Prevent major complications. Provide analgesia where possible, and provide anesthesia for the cesarean section. Those are the roles of the anesthetist. But don't run with the patient who is unstable to theater just because the patient is convulsing. That's the wrong way to do. You can save that patient by spending a few minutes, including admitting that patient to ICU for stabilization as you prepare to take the patient to theater. I remember in the past, over 10 years ago, we were in an institution where anytime there was a patient who came with eclampsia, the patient was wheeled directly to theater. And I don't want to tell you what the outcome was, and because you know what the outcome will be. A patient who is having very high pressures, patient who's not controlled pressures, patient who is convulsing continuously and getting hypoxic, and you are rushing that patient to theater, you are going to induce the patient, intubate the patient, start anesthesia in the rush to get the baby. Many times the baby might even be premature and might not live. And then in the rush, you are ending up with a maternal morbidity, severe maternal morbidity or maternal death. So we have to be very careful about this. Stabilize your patient. Do everything before you rush for cesarean section. And many surgeons will agree with you that let us stabilize the patient, because at the end of the day, if the mother lives, even if she loses that baby, she will be able to get another baby. But if she dies and even the baby dies, then there is a double loss. And if the baby lives and the mother dies, still there is a major loss there. So what are the major complications of eclampsia that we need to take care of as we think about these patients, as we manage these patients? There's the HELP syndrome. There's the usual intrauterine growth retardation for these babies. There may be abruptio placenta. There may be neurologic deficits. The patient has convulsed and even had an intracranial hemorrhage. So take your time, stabilize the patient, and see what is best for that patient. Your patient may have even aspirated. The patient might be in DIC, and here you are rushing to put a spinal on that patient. The patient might be having in pulmonary edema. Patient might be in renal failure. Or the patient may have just had a cardiac arrest and you are rushing the patient to theater. Do something about the resuscitation before you rush to theater. And then again, teamwork, teamwork, teamwork. Now we move to sepsis in obstetrics. It is not such a major issue in our setup, except that it doesn't rank as number 1 or 2. It is number 3. But worldwide, it seems to be more important because they have managed to handle their hemorrhages. They have managed to handle their hypertensive diseases much better. And therefore, sepsis now becomes number one in the developed world. Sepsis in pregnancy and puerperium remains a significant cause of mortality in our setup. It may start as chorioamnionitis and you do nothing about it and your patient will die. Worldwide, it accounts for 15% of maternal deaths. Major morbidity arising from obstetric sepsis includes fetal demise, organ failure, chronic pelvic inflammatory disease, chronic pelvic pain, bilateral tubal occlusion, and infertility. All those are consequences of obstetric sepsis or sepsis in pregnancy. So we have to all look at all those as some of the things where we need to help each other in preventing. So we need to think of how do we diagnose these cases. Sorry. So we need to be very careful. Sorry, I need to deal with that first. So we go back to sepsis. I had not looked at it. Early recognition and diagnosis of sepsis with rapidly instituted therapy are the key to ensuring a good outcome. Remember, sepsis in obstetrics is just like sepsis in any other patient. Therefore, you must do early recognition, early diagnosis, and early institution of therapy, rapid institution. You hit hard and then you do your investigations and move forward and then de-escalate once you have discovered what bug you are dealing with and what antibiotic is best for your patient. You don't have to continue with the big guns. Sepsis may arise in obstetric patient at any time. It can be before delivery, like I said, chorioamnionitis, during labor, contamination because of the multiple VEs that are done, or in the postnatal period. If sepsis is suspected, regular frequent observations must be made, and use of modified early obstetric warning signs chart is recommended, the MUSE chart. Urgent referral to the critical care team in severe or rapidly deteriorating cases is important. And in our setup, you will agree with me that most of the intensive care units are mainly manned or mainly managed by anesthesia personnel. We are beginning to get more and more medical practitioners specializing in critical care. Some of them are anesthetists, some of them are surgeons, some of them are physicians, some of them are even obstetricians, and they will then deal with specific cases. We are beginning to get obstetric ICUs where we would like to get the obstetricians interested in critical care managing the ICUs, together with, of course, the other people who will be dealing with the ICU, pulmonologists, cardiologists, and so on and so forth. The anesthesiologist will always be handy when it comes to airway management, when it comes to being sure of the lines and so on, and being sure that the patient is well ventilated. All these are important. And every time there is sepsis, even when the patient goes to the critical care unit, the obstetrician must be involved. You must involve the obstetrician because they will see the other side of the patient, which you will not see. So just a slide or two on anesthesia considerations of a pregnant woman with COVID. You know, these are COVID times, so we must mention something. There's limited data to show serious complications of COVID infection in pregnancy. But we know that severe adverse maternal and perinatal outcomes, especially preterm delivery, intensive care unit admission, and neonatal and intrauterine death have been reported during these COVID times. To prepare for the likelihood of caring for women during labor and cesarean delivery, anesthesia professionals must know how to provide safe, patient-centered care, and how to protect every member of the obstetric team from exposure to the virus. Remember, if you have to do a procedure like intubation and extubation, you are giving a general anesthetic, you are likely to expose people to aerosol contamination. And of course, not just other people, even you yourself will be contaminated. And that is why it is important that when, and this is something we have discussed in another webinar, is that when you are doing a general anesthetic in a patient who is COVID positive, then during intubation in the theater itself, you must have very few and essential personnel. The anesthetist, the assistant to the anesthetist, and probably the runner nurse to help you in case you need anything. Otherwise, keep everybody outside until you have intubated your patient and you have stabilized and there is no further risk of aerosolization before the other team comes in. So there have been reports of patients who have been done cesarean section. There is no contraindication to a regional anesthetic in SARS-CoV patients. So COVID patients, again, we prefer to give a regional anesthetic. If the patient wears a mask, patient is well taken care of and you minimize the risk of spread of any fluid and so on, you are better off with the regional anesthetic. And the SARS-CoV-2, which is the coronavirus, which causes COVID-19, it is highly virulent and can be transmitted through droplets from just the normal breathing. That patient who is talking to you can actually be infecting you. That patient who is sneezing and coughing, or the patient who is screaming in the labor and delivery room can cause a lot of aerosolization of body fluids. So you have to be very careful. You have to make sure that every member of the team is protected. But information from a small number of case reports which we have seen indicates that the clinical findings of the pregnant women with COVID-19 are actually similar to those with non-pregnant women. So there's really nothing very special, but the precautions must be the same and you must treat that patient with care. And we know for a fact that such patients, if you can avoid to intubate them, if you can avoid to interfere with the airway or manipulate the airway, you are actually saving that patient from further contamination of the environment. The severity of the disease in pregnant women is similar to that in other adults. So the fact that they're COVID-19 and they are pregnant may not quite make them any worse off than any other patient. So care must be taken, and that is something that has been discussed before, and we can still discuss it in another forum. So, in summary, the main causes of maternal morbidity and mortality in Kenya or low and middle income countries is hemorrhage, number 1, hypertensive diseases, number 2, and sepsis, number 3. The contributing factors are varied, and we have mentioned them, and there are many. Prevention and management of conditions leading to severe morbidity and mortality will depend on the multidisciplinary teams. It will depend on infrastructure. It will depend on equipment, socio-demographic and economic factors, patient factors, and the most important statement in this particular bullet is planning ahead. Always plan ahead. I'll give you an example. Today, I was in a certain hospital, and there was a patient whom the surgeon had wanted to deliver vaginally, normally. Then the surgeon went to review that patient. She was already in labor, and he found that there was more than just the normal show in that patient. And he said, no, let us take this patient to theater for the cesarean section. At cesarean section, we actually found there was an undiagnosed type 2 placenta previa. So you can imagine if that patient had been left and had been found in a pool of blood with people running here and there, trying to look for blood, trying to look for theater, to look for everything, that patient would probably have died. So the issue here is planning ahead. Some yet to be identified the factors may also play a role in maternal morbidity and mortality. Remember the effect of the free maternity care in Kenya. We improved institutional deliveries, healthcare, patients coming to healthcare facilities for deliveries, but we did not improve the mortality rate, maternal mortality rate. So there must be something. General anesthesia and anesthetic practice by inadequately trained staff is a major factor in maternal morbidity and mortality. That is another fact that we know. And we know, for example, in the early 90s and below that before, we had many patients landing in our ICUs because of poor reversal from general anesthesia, hypoxic brain damage because of difficult intubation, and so on. Today, you walk into KNH ICU, you are unlikely to find a patient who has purely an anesthetic problem bringing the patient to that ICU. Most times, it will be a patient who has had severe hemorrhage and therefore went into acute kidney failure and has been transfused quite a lot and required monitoring, or the patient had developed as hypertensive disease in pregnancy, and that patient requires close monitoring and close control, or the patient has sepsis and has come in septic shock and is being managed in the critical care. So basically, those are the things I wanted us to discuss. And with that, I think I finish my presentation, and I welcome questions, and I welcome comments. I welcome inputs from anybody who has something to tell us, because this is a major concern in this country. Thank you very much.
Okay, thanks a lot, Dr. Olan, for that very incisive presentation, covering very, very deep details. A lot of questions and concerns have been raised on the chat, but you're going to handle them later after a short presentation from our partners Ferring Pharmaceuticals. So at this point, I'm going to invite Safina Ngugi for a short presentation, and then we'll proceed from there to the question and answer session towards the end.
Okay, sorry for that. My name is Safina Ngugi from Ferring Pharmaceutical. And Ferring Pharmaceutical, let me just give a brief preview of what Ferring Pharmaceutical is. Ferring Pharmaceutical was founded in 1950, and it is a research-driven specialty biopharmaceutical group committed to helping people around the world build families and live better lives. It is located in Switzerland, and we are leaders in reproductive medicine and women's health, and in specialty within gastroenterology, urology, and endocrinology. I believe the reason why all of us are gathered here in this platform is because all of us, we are looking forward to having a happy mother and a happy baby walk home after they come to the hospital when the mother is pregnant. But this has not always been the case. Reason being what Dr. Olan has really discussed in details, and majorly this is contributed by Pph. And like we have seen in other studies in the previous discussion, also if you look at the New England Journal of Medicine, that was released on 27th of June 2018, it shows that hemorrhage is the largest direct cause for maternal death. And it is worrying because around 70 women die each year worldwide due to Pph. And this translates to after every 8 minutes, a mother dies. And like we have seen, Pph is mostly unpredictable. It can happen to the young. It can happen to the mother who is delivering for the first time. It can also happen to the mother who has delivered even 5 times. But mostly Pph is caused by uterine atony, like we have seen. But the beauty is active management of that stage of labor can prevent 60% of Pph. So in Ferring, we have said we are leaders in reproductive health. And we would like to introduce to you the product that we have, the medicine that we have that can be of great help to our mothers. And we are saying that we are one step ahead of PPH. And in the next few slides, I'm going to discuss what Pabal is. And we have done a comparison with oxytocin. What is carbetocin? Carbetocin was created by making several modifications to the oxytocin structure. And this one helped in the reducing enzymatic degradation and also prolonging the half-life of the peptide. And if we compare the major blood loss, blood availability can be a big issue. And we have done this slide, this study was carried out in 2009, and it shows that Pabal reduces the major blood loss. Pabal reduces the major blood loss by more than 50% when compared to oxytocin. And in this study, it shows that 58 fewer patients with blood loss, that is more than 500 ml with Pabal versus oxytocin. In the next slide, I'm going to discuss about how long does it take for Pabal before you add additional intervention. Pabal is associated with significantly longer time to additional intervention. And in this study that is Obstetric Gynecology, which was carried out in 1999, it shows that Pabal, time to additional oxytocin intervention, it was 10 times longer with Pabal than with oxytocin. And if we break this down, you need extra like 109 minutes before additional treatment with carbetocin, with Pabal versus oxytocin. And in continuation, this study was carried out, it's a journal of prenatal medicine, which was carried out in 2013. It showed that a single injection of Pabal is more effective than continuous infusion of oxytocin to prevent the PPH in women at high risk, with a similar hemodynamic profile and minor antidiuretic effect. In fact, in this study, with Pabal, there was no woman who needed additional oxytocin compared with oxytocin group. And here, I would like to discuss the hemodynamic effect. And if you look at Pabal and oxytocin, they have the same hemodynamic effect. This study was that it was from Cochrane Database of System Review in 2012. And Pabal and oxytocin treatment group, they showed similar level of cardiac output, stroke volume, and systemic vascular resistance. We would like also to share with you a slide that shows about antidiuretic effect, which was from still the Journal of Prenatal Medicine 2013. And despite Pabal is a synthetic analog of oxytocin, the small difference in the molecular structure could determine the difference in biologic function as the absence of antidiuretic effect, which is a very important result. And with Pabal use is associated with significantly lower antidiuresis compared with oxytocin. And also, I know even if you have a very good product, but you are not assured of the safety, you may not be able to use it. And that is the reason why we carried out these slides about safety. And Pabal has the comparable safety of oxytocin and Pabal. They have comparable safety profile as it indicated in this study. And also, I would like to discuss what Australian and New Zealand College of Anesthesiologists conclusion for the review they were doing. They concluded that practicing anesthetists, they will appreciate the practical advantage of carbetocin, which include the avoidance of error-prone infusion and reduced need for uterine intervention. And I would like now to discuss what is the take-home message for Pabal. What benefit does Pabal offer? What should healthcare providers use Pabal? And Pabal eliminate the need of continuous infusion. It is a simple, easy injection. And Pabal is stable at room temperature. You can imagine, you are not going to get worried about the power blackouts. I know there are some institutions whereby they don't have backup generator. And if you are not able to put your product in a cold chain, it may not be effective. But with Pabal, it is stable at room temperature at 30 degrees, and it can be stored in operating room. In fact, you can put it even in the surgical tray. You can simply put it in your pocket when you're going to use it to your patient, because it is a room temperature product. And Pabal return uterine tone. If you administer slowly over 1 minute, you will get firm contraction within 2 minutes. And the beauty is you will get a sustained rhythmic contraction for 1 hour. And that is one of the reasons why you will get the risk of blood loss will not be there. Right now, we know that the blood availability is not there. So you will get the risk of blood loss will not be there. And like we have discussed in the previous slides, it is significantly increases the time before further uterotonics. And we have seen this about the safety, and also something that is very key. It will help in the streamlining the surfaces, and this will positively impact on theater efficacy, because we have seen when one patient gets PPH, you cannot manage that patient alone. You have to manage this patient as a team. And Pabal is more efficacious and cost-effective than oxytocin in preventing uterine atony. It cannot be compared with blood transfusion. It cannot be compared losing that child, losing that mother. And the most important thing, especially for the healthcare providers and the patient, it is convenient for the patient, and it will give healthcare providers peace of mind for the medical staff. You don't have to be called back when you have already operated on the patient, and now the patient starts bleeding again and you have to go back to the hospital. When you give Pabal, you'll have peace of mind that your patient is well taken care of. And I would like to discuss, to show you the dosage and administration of Pabal. Pabal, you can see the bottle down there. It comes as one vial. It's a single dose of 100 microgram per ml. It's 1 ml. And how do you administer it? It is administered slowly over 1 minute. It is a slow IV push. And how do you administer Pabal? Pabal is administered as soon as possible after delivery of infant, preferably before the removal of the placenta, because it is going to give you a continuous rhythmic contraction for 1 hour. If you can allow me, I will share with you a video. It is just a 1 minute video on how you can administer Pabal. Just a second.
Carbetocin, the long-acting analog of human oxytocin in Pabal, specifically targets uterine atony. Carbetocin has a slightly modified chemical structure, improving its stability and extending its half-life to 42 minutes. It stimulates uterine contractility within 2 minutes and lasting for 1 hour, and also raises uterine tone. Pabal is administered as a single intravenous injection of 100 micrograms per milliliter of carbetocin over 1 minute, only after delivery of the infant by cesarean section. After injection, carbetocin is carried rapidly to its site of action, the smooth muscle cells in the uterus. Here it binds to oxytocin receptors. In this way, a signaling cascade is started. Prostaglandins are produced and calcium is released from intracellular pools. As a result, the smooth muscle cells of the myometrium start contracting regularly. This causes the leaking blood vessels in the uterus to be compressed and to constrict. The prostaglandins also stimulate intravascular thrombosis in the placental bed. The overall effect? The bleeding stops and uterine involution is furthered. Carbetocin regulates physiological hemostasis and uterine involution, providing a good start for mother and child.
And thank you for watching the video. And what we are asking, now we have Pabal in the market. We know that our mothers are suffering. I know all of us who are tuned in, we can give our mothers a good start, and they can go home with their children happy. And this is the picture we are looking for the patient, for our patient. Thank you very much. Thank you very much. Thank you.
Thank you very much, Safin, for your presentation.
Thank you. You're welcome.
And thank you everyone for attending. Now we are going to handle the questions that have been coming in. I must say there's been a lot of activity in the chat. I'm going to start with one comment here from Dr. Farai Madzimbamuto. I think this is from Zimbabwe. Dr. Farai comments are very important to us as anesthetists or anesthesiologists, and he says that it's unfortunate indeed that we are involved at the end of the care pathway for obstetric patients. And he thinks that given the number of physician anesthetists, it's going to be a long shot changing MMR by anesthetic interventions only, unless we come up with different strategies. And he does have two proposals here. First is to see how we can scale up the numbers. And secondly is ways in which we can reach into the obstetric care much earlier. And I think this is a challenge to the obstetricians that we are having. You should be able to involve the anesthesiologists or anesthetists much earlier in your care, as early as in the ANC. And it's the same vein that Dr. Susanna Bulindo is asking Dr. Lang if there is a way that we could incentivize young anesthesiologists to subspecialize in obstetric anesthesia. Now, Dr. Lang, there are a number of questions here, and I'm trying to summarize them. There seem to be a lot of inquiry as far as this drug called tranexamic acid is concerned. And the first one is from Moses. Moses is asking, is it safe to make tranexamic acid a routine prophylaxis for cesarean section? Dr. Nyandwi from Siashuka, that's in Kigali, would like you to comment on the effectiveness of desmopressin compared to tranexamic acid in PPH. I hope you'll be able to remember this, Dr. Lang. And Zachary Morioki is asking, is there a dose limit for tranexamic acid if you don't have blood? As in, how much can you give? Maybe you can start with those ones, Dr. Lang.
Thank you very much. Now, one, whether to use tranexamic acid as a routine, there are two schools of thought. There are those who believe that you need to give it only when there is PPH, and there are those who believe that it should be used as a routine. And for me, I'm somewhere in the middle. I look at the procedure as it goes on. If I see that the bleeding, because normally we expect blood loss to be about 400 mils in a cesarean section. If I see that there is quite a bit of blood loss, I don't wait for the surgeon to tell me. Luckily, I work with surgeons who talk to me. We discuss many things together. So we will always agree on whether to give or not. But most of the time, by the time they ask me whether I've given, they find I have already given. So personally, I'm more towards the routine use of tranexamic acid. What is the dosage? The dosage recommended is 1 to 4 grams start. 1 to 4 grams start. If you have a patient, say with placenta, accreta, pacreta, the one where there is going to be definitely massive hemorrhage, then you are better off going for the bigger group, the bigger dose, which is 4 grams. But the dosage ranges from 1 gram to 4 grams. I see sometimes people give 1 gram and then they repeat depending on the circumstances. There's nothing wrong with that. But you go up to 4 grams. And please note that tranexamic acid does not increase the risk of your patient developing DVT. So don't be worried about it. Then the question of desmopressin. Unfortunately, I have no experience with it in obstetrics because it is not a drug that is readily available in our cuts. So I'll probably not want to comment on the difference between desmopressin and tranexamic acid. If you look at it in terms of pharmacology, pharmacokinetics, it's probably just as effective as tranexamic acid, but I will decline to commit myself as to which one is better.
Thank you, Dr. Lang. The second batch of questions, again, is got to do with the drugs, that is syntocinon and cytotec that are commonly used. And again, it's the same thing about the dosage and routes of administration. What would your comment be? What are the maximum doses, rectal, sublingual, etc.?
Syntocinon is one drug that we tend to overdose patients with. Actually, the WHO recommends that after the delivery of the baby, if you want to give syntocinon, just give 2.5 units. And if that 2.5 units is not appearing effective, then you double the dose. Keep doubling the dose. That's the way one needs to do it. You keep doubling the dose. But any dose that is beyond 20 international units of syntocinon, like sometimes I see people putting 40 units in 1 liter, 60 units in 1 liter. Most times, the receptors are already occupied. Adding the drug only increases the side effect profile of the drug. If it is not going to act, it will not act. So people must have that threshold. You must have a threshold of looking at the effect of your drug. If you have given syntocinon 2.5 units, and the surgeon tells you this